Hi, I'm Steve Selig, founder of Fit Test, and in part 3 of my 5-part series on the European Society of Cardiology guidelines for exercise in patients with cardiovascular disease and cardiometabolic disease. Part 3 is on the topics of aortopathies, hypertrophic cardiomyopathy, dilated cardiomyopathy, myocarditis, and a little bit on congenital heart disease, especially adult congenital. And as for all the other parts in this series, I'm just letting you know that you can get free downloads of all of the information on these excellent guidelines, full text, pocket guidelines, and a slide set. So first of all, aortopathies. I'll just go through a few common examples, and I've made YouTube videos about all of these. So you can search for me, Steve Selig, on YouTube, and you'll find all of the videos that I've made so far. Some of them haven't been released into the public yet, but they will be, so keep coming back. First of all, coarctation of aorta, which is a defect describing a focal narrowing of the aorta in the upper descending aortic region usually, and that then creates all sorts of blood pressure and other hemodynamic problems, and eventually can cause heart failure if not corrected. Aortic aneurysms, which is a bulging out of a wall thinning of a major artery, and you can see here the ones that are really serious, such as arteries supplying the heart, the brain, the intestine, the spleen, lower limbs, and so on. And the third example, aortic dissection, where you've got a longitudinal splitting of an artery wall, where blood can invade a non-conduit portion of the artery, where blood is still flowing through the conduit portion, and then the non-conduit forms a blood clot. And this one, together with the aneurysms, has a risk of splitting and rupturing. So coming to exercise recommendations by the ESC for aortopathies. First of all, prior to engaging in exercise in the first place, risk stratification with careful assessment, including advanced imaging of the aorta, and exercise testing with blood pressure assessments is recommended. Now, in the relation to the last one of those, exercise testing with blood pressure assessment, I've done case studies on this in relation to other but very similar related conditions. I think I've done a case study on Ehlers-Danlos, where you have to be very careful around controlling blood pressure very strictly in people with risk of ruptures. And Ehlers-Danlos can have multiple aneurysms and dissecting arteries. And that's why I did that case study. So you can probably find that also on YouTube. So we've got to be very careful in that pre-participation phase in doing our correct assessments. We're relying on medical practitioners to give us or to do the imaging of the aorta and make sure that where possible, this exercise is as safe as possible. Now, coming down to the bottom part of this slide, participation in individualized leisure exercise programs may be considered in high-risk individuals. But competitive sports are not recommended in individuals who are at high risk. So in my case here, I would do exercise testing with really strict blood pressure measurements to work out what's systemic blood pressure is happening to systemic blood pressure, and by inference then into the aorta, except in the case of coarctation, where you can't do that because you're measuring the pressure distal to the defect. Hypertrophic cardiomyopathy, congenital condition, participation in high-intensity exercise or competitive sports, if desired, with the exception of those where occurrence of syncope may be associated with harm or death, may be considered for individuals who do not have any markers of increased risk following expert assessment, underline that. And then down here underlined in red, participation in high intensity exercise, including recreational and competitive sports, is not recommended for individuals who have any markers of increased risk. So really, you've got to work very closely with the cardiologist, particularly in order to produce a safe exercise plan. Now, these are, the recommendation is at level 3. In other words, high intensity exercise is not recommended. But the level of evidence at this stage is only at C, so it's only relying on expert opinion. Now, follow-ups. Annual follow-up is recommended for individuals who exercise on a regular basis, and even 6-monthly follow-up should be considered in adolescent individuals and young adults who are more vulnerable to exercise-related sudden cardiac death. We now come to arrhythmogenic cardiomyopathy. Participation in high-intensity recreational exercise or sports or any competitive sports is not recommended in individuals with arrhythmogenic cardiomyopathy, including those who are gene positive but phenotype negative. Now, again, the recommendation is at level 3, but the level of evidence is only at B. In other words, only a single clinical trial or larger type observational trials. Follow-up, similar to what we had with hypertrophic cardiomyopathy, annual follow-up is recommended for individuals who exercise on a regular basis. So keeping your clients in touch with their medical specialists is required. 6-monthly follow-up should be considered in adolescent individuals and young adults who are more vulnerable to exercise-related sudden cardiac death. Now we come to a unusual condition. To be honest, I've never had a case with this condition of left ventricular noncompaction. And this describes a large amount of trabeculae. And what is shown here is in the left ventricle, a large amount of left ventricular trabeculae, which is really affecting the left ventricular free wall and the apex of the heart at left ventricle through to the septum. And you can see the non-compacted myocardium is where you've got all the trabeculation, and then you've only got a thin wall of actually compacted myocardium, which is the normal myocardium. And by contrast, on the right ventricle, we can see that it's a normal-looking ventricle, although enlarged. So left ventricular non-compaction, the exercise recommendations by the ESC is that participation in recreational exercise programs of low to moderate intensity, if desired, may be considered in individuals with left ventricular ejection fraction low, but not extremely low. So in that 40 to 49% region, which is sort of mid impairment in ejection fraction. In the absence of syncope and frequent or complex ventricular arrhythmias on ambulatory Holter monitoring or exercise testing. So there's really a lot of workup that needs to be done here in order to give these people anything more than low intensity exercise programs. So again, care needs to be taken. Now, participation in high or very high intensity exercise, including competitive sports, if desired, may be considered for individuals who are gene positive for left ventricular non-compaction, but phenotype negative. Participation in high intensity exercise or competitive sports is not recommended in individuals with any of the following. That is symptoms, left ventricular ejection fraction below 40%, and or frequent and or complex ventricular arrhythmias on ambulatory Holter monitoring or exercise testing. Coming to dilated cardiomyopathy, participation in high or very high intensity exercise, including competitive sports, with the exception of those where occurrence of syncope may be associated with harm or death, may be considered in asymptomatic individuals who fulfill all of the following. Mildly reduced LV systolic function, that is ejection fraction just a little under normal, 45 to 50%. Absence of frequent and or complex ventricular arrhythmias on ambulatory Holter monitoring or exercise testing. Absence of LGE on cardiac magnetic resonance imaging. Ability to increase ejection fraction by 10 to 15% during exercise. No evidence of high risk genotype. And follow-up recommendations for dilated cardiomyopathy. Annual follow-up is recommended for individuals with dilated cardiomyopathy who exercise on a regular basis. So again, emphasizing with that red underline that you as an exercise professional and your client, you need to ensure that your client is undergoing specialist annual follow-up to track what's happening with the dilated cardiomyopathy in order to continue to provide safe exercise interventions. Myocarditis, which describes an inflammation of the heart muscle, often as a sequelae to an infection, for example. Among individuals with a probable or definitive diagnosis of recent myocarditis, participation in leisure time or competitive sports while active inflammation is present is not recommended. So level 3 for the level of recommendation, but the absence of evidence is really just based on expert opinion here. Participation in moderate to high intensity exercise for a period of 3 to 6 months after acute myocarditis is not recommended. So what we're saying here is stick to low intensity exercise only for a period of 3 to 6 months after the myocarditis, because it can really produce rapid progression to heart failure if you don't follow that guideline. Participation in leisure exercise or competitive sports involving high intensity in individuals with residual myocardial scar and persistent LV dysfunction is not recommended. So again, for those of you who are fans of high intensity interval training, this is a class of client where this is not recommended. Please don't do it. Congenital heart diseases, and I'm really just going to scratch the surface here because congenital is just a huge area on its own, and it really depends on the nature of the congenital heart disease. It certainly is going to be heavily influenced by how much corrective surgery was done to the baby and the young and the child and the young adult, to see where they're at in terms of reaching adult congenital heart disease and what deficits are remaining. So this really needs to be done on a case-by-case basis. But that said, just to underline a few things in red, a discussion on exercise participation and provision of an individualized exercise prescription is recommended at every coronary heart disease patient encounter. Assessment for ventricular function, pulmonary artery size, aortic size, arrhythmia risk is recommended in all athletes with congenital heart disease. And competitive sports are not recommended for individuals with adult congenital heart disease who are in New York Heart Association class 3 or 4, or with potentially serious arrhythmias. Now, I just want to finish this section by saying that not covered in the European Society guidelines, but are related to the topics covered in part 3 of this series of presentations, conditions such as amyloidosis and sarcoidosis, arrhythmogenic right ventricular dysplasia or ARVD, other myocardial infiltrative diseases, and connective tissue diseases such as Ehlers-Danlos syndrome. Taken together, these various conditions can cause life-threatening arrhythmias all the way up to sudden cardiac arrest, sudden cardiac death, rupture of cardiac valves or central arteries, and symptoms of acute heart failure in response to exercise. So these are the references that I've been basing this series of presentations on. Thank you for listening to this short presentation on some of those less common cardiac conditions that you may come across all of them carrying significant risk that you need to manage as an exercise professional. As always, you can contact me at info@myfittest.com.au. Very happy to hear from you, and thanks for watching this short video.